Hello, it's Dr. Sam Fiala, and this will be a brief lecture on defining abnormal behavior. So we'll talk about in this lecture what makes behavior abnormal, what's the difference between abnormal behavior and what we consider psychopathology, and then we'll go over some terminology that's helpful in our future discussions of abnormal behavior and psychopathology. Okay, what makes behavior abnormal? Well, that it's not normal. When we say not normal, what do we mean? Well, a lot of times what we mean is, in terms of behavioral scientists, when we say not normal, we mean statistically deviant. So if we're looking at the normal curve, right, we say abnormal means from the norm, away from the norm. Well, the norm is everybody in the middle of the curve, right? If you graph people on any behavior or characteristic, a lot of people will be the same, and all those people will pile up in the middle of the curve. Some people will have more of a characteristic, more of a behavior. Some people will have less. The further you get from the typical, the average, or the norm, the fewer people that have that. So how far from typical do you have to be considered abnormal? How far is statistically deviant? Well, it depends what we're talking about. As a general rule in behavioral science, we often use 2 standard deviations away from the mean as a marker for, okay, that's exceptional. I can tell you, looking at testing materials for psychopathology, they often use a slightly lower threshold, maybe 1.5 standard deviations. So if you're looking at a test that's a standardized test where the average is 50 and you've got a standard deviation of 10, then a score of 65, which would be 1.5 standard deviations above the mean. Okay, 65 is the cutoff where we start thinking, okay, there's some clinical significance here. This may be indicative of some abnormal behavior. But again, depends on what behavior we're talking about, what norms we're talking about. Okay. The other thing we use to decide if something is abnormal is just our own interpretation. Like when I look in the mirror and I say, okay, well, this is me, and I look at that behavior, well, I don't do that. Well, then I guess it's abnormal if it's not me, right? So there is a significant subjective component to our judgments of what makes something abnormal. Right? If you like to, when you eat your M&Ms, you like to empty the package out, divide them up by color, and then eat them in order. All the red ones first, then the green, then the orange. Of course, that order makes perfect sense to you. Well, if you do it, it's not abnormal. Now, let's say it's your sister or your cousin that does it, and you wouldn't do that. Well, now you might make the subjective judgment. Well, that's abnormal behavior. Okay. So, to be abnormal behavior, it needs to be abnormal, which typically means it doesn't happen to everybody, or it just doesn't happen to you, depending on your perspective. It also needs to be behavior. And what do we mean by behavior? Obviously, we mean behavior, things you do, actions. But more broadly speaking, in psychology, when we think of behavior, we also talk about thoughts and feelings being behaviors as well. So people acting strangely, doing odd things, that would be abnormal behavior. Having thoughts that are different, and also having feelings or emotional reactions that might be abnormal. All these things are considered behavior. One important thing to think about too as we go through this study of abnormal behavior is some of the behavior we'll look at and talk about is overt, so it's observable. You can see that somebody is talking to someone who nobody else can see. Okay, well, that's overt behavior that is arguably abnormal. Now, from the individual's experience, if they hear a voice talking to them that no one else can hear, okay, well, they can't observe that. No one can observe that they're hearing that. So that's covert behavior, right? So whether or not the behavior is overt or covert often depends on perspective. So whether or not somebody else can observe the behavior, or if it's only observable to yourself. And if it's only observable to yourself, well, then we're going to rely on self-report, right, to identify the presence of abnormal behavior. Or possibly, if you're having that covert behavior experience of hearing a voice, well, that may then lead to a secondary overt behavior if you talk back. Now people can see you talking to someone who's not there. Okay, so abnormal behavior is behavior, thoughts, feelings, actions, that's statistically deviant or just subjectively different from myself. Right? But that's pretty squishy, right? And so a lot of what we'll focus on in this class is psychopathology, which moves beyond just, oh, that's abnormal, that's odd behavior, weird behavior, to a little more definable in terms of a psychological disorder. So we talk about the term psychopathology. It technically refers to the study of psychological disorders. But we'll also use the phrase frequently to talk about the presence of a psychological disorder. So if you say somebody's exhibiting, oh, I think they're exhibiting some psychopathology, you don't mean they're exhibiting the study, you mean the actual disorder. So that is pathological in a psychological sense. So there's another chapter we'll cover in a future lecture about, in greater detail, about diagnosis. But generally speaking, when deciding if something rises to the level of psychopathology, that it is a psychological disorder, there's three broad criteria we look at. One being psychological dysfunction, right? So there's some assumption that there's a typical psychological process that's not functioning typically. It's having some dysfunction. So typically, if someone tells you a string of numbers, it's 7 or less, you can repeat it back to them, within a minute or two. If you have some cognitive dysfunction with dementia, some sort of amnesia, some sort of memory impairment, you may not be able to repeat back those numbers. That would be a psychological dysfunction. Right? You could also say that if someone told you, nice to meet you, that generally wouldn't have a lot of affective content and is unlikely to generate a large behavioral response. But if you have some psychological dysfunction where you're going to misinterpret the nice to meet you as, oh, this is somebody who's plotting to kill me, and they're only saying that to get close to me, and now I'm having a significant fear response and then a behavioral response of running away or attacking, okay, well, that might be a psychological dysfunction, right? The functions of the mind aren't working the way they typically would. Another criteria would be personal distress or impairment, right? And the thing is, with these criteria, you often can't just meet one and they go, oh, yep, that's psychopathology. Because let's think about that psychological dysfunction. Let's say someone is incredibly shy, right? And a lot of this is a matter of degree, of course. But let's say so shy that unable to meet new people. Now, it's possible that might not bother you, and so it may not cause personal distress. So it could have psychological dysfunction, but no distress. And it's possible, too, it might not cause impairment. If you were independently wealthy and didn't need to meet people to earn a living or and had no need for relationships, then you could argue that that person, even though they were, by many standards, pathologically shy, so shy they can't go out and do things, well, if they don't want to go out and do things, well, it's not a disorder. But if they want to do things, okay, now it's a disorder. Okay. So you have to have kind of all of these criteria, and all the criteria are a matter of degree. So personal distress, it bothers you, or it causes some impairment. When we talk about impairment, we're talking about impairment in usually a major area of functioning. So vocational, so your job, educational, being able to study, complete a program of learning, or interpersonal, being able to interact with others in a typical fashion. Again, there's some assumptions built in there about what people are supposed to do. People are supposed to work. They're supposed to be in relationships. They're supposed to be able to learn. Which again are assumptions, and as we'll talk about in the future, probably culturally bound assumptions to some degree. Related to that, where it kind of saves the definition from being, oh, well, this is just clearly culturally biased. Well, not necessarily, because to be psychopathology, it also has to be atypical or not culturally expected, right? So if you're in some culture where work isn't valued as much as it is maybe in Western cultures where that seems to be all we think we're supposed to do. But if you come from a culture where that's not the main focus and you have some psychological dysfunction that keeps you from being able to work, well, it may not be impairment because there's this cultural piece that says, well, no, you don't need to work. There's no expectation for that. So this thing that's going on needs to be some psychological process that's not working a typical way cause distress or impairment, and then be atypical, which goes back to that kind of statistically deviant, or not culturally expected, right? So if you were to dress up in a monster mask and run down the street shouting down with tyranny, we might think, well, that's some psychopathology. They're acting crazy, right? Now, if that person is engaged in political protest, okay, well, now it's got cultural context, and it's no longer necessarily psychopathology. Now, what if the person had schizophrenia and was involved in political protest? Well, now it's really hard to figure out. And again, that's something we'll talk about more when we get to the chapter on diagnosis and assessment, and talk about how difficult it is to kind of look between those shades of gray and identifying, yes, it is, no, it isn't psychopathology. It's not really clear cut. But decisions do get made. Who makes those decisions? Who decides whether or not somebody has psychopathology? You might think, well, the individual decides. They self-diagnose. Well, you certainly could self-label, but you can't self-diagnose, because the diagnosis is a decision made by someone with a license, right? They've been licensed by a governmental body, typically a state, to practice medicine, psychology, or counseling. So if it's a physician, it's most likely going to be a psychiatrist, right? That's somebody who went to medical school, got their MD, first 4 years, like every other doctor, studied the same stuff, and then after those 4 years went and did an internship, and then 3 years of residency in psychiatry, where they learned about mental illness and a lot about psychopharmacology. Or if they're not a physician and they have a doctoral degree, it's going to be probably a psychologist, either clinical psychologist or counseling psychologist. And their license is the licensed psychologist, LP, and they can apply diagnostic labels as well. And then less commonly will be master's level counselors and therapists, licensed professional counselors, marriage and family therapists. In a school setting, possibly a specialist in school psychology. They tend to be familiar with diagnostic labels and need to be, because their clients may come in with them, but they're less likely to assign them in many instances, and they often use a smaller variety of labels than the doctoral level practitioners. But again, it's these people that have been imbued with power by a state to make decisions that, yes, you have psychopathology, you meet criteria for a disorder, no, you don't, right? And that's important, that it is a decision, right? It's not a discovery of fact, it's not a divine revelation, it's just an individual making a decision based on evidence to the best of their ability. And as we all hopefully know, decisions aren't always correct. Okay, on to some terminology. Presenting problem. So this is what people typically come in with. They present with some concerns, and the presenting problem may be from the perspective of the person, the client, saying, hey, I'm really having a problem with this, or it may be someone else's concern. They're bringing in a family member, or if it's the police, bringing in a suspect, saying, hey, this is this behavior that we are concerned about. But usually there's something that's going on that they're concerned about. So what the presenting problem is a problem. So the individual sees it as a problem. Some significant component of their system sees it as a problem. So it is a problem, but it may not be the problem, right? So it may not be the thing that really needs to is at the heart of the issue. So a client that comes in and says, yeah, I need some help communicating with my mom. She just won't stop hassling me about eating enough. She says, I don't eat enough, and it really bothers me. I need some assertiveness training to tell her to leave me alone. Okay, that's probably a problem. But it's also possible that this individual has an eating disorder, maybe anorexia nervosa, and that may be kind of a core problem. But again, this communication with the mother about eating, as we'll see later, probably feeds into that problem and is a part of it. But that may not be all we work on. Is, yeah, our goal now is to get your mom to leave you alone so you can starve yourself to death. Well, not really. So the presenting problem is important, but it's not always necessarily the problem. Okay, prevalence and incidence. Prevalence is the number of people with a disorder in a population at a given time, right? So the prevalence of ADHD in 2008. So in 2008, there were this many people that currently had diagnosis of ADHD. Or you might also hear the phrase lifetime prevalence. So that's not across their entire lifetime from birth to death, but it's okay. In 2015, the lifetime prevalence of ADHD was this percentage. Okay, that means in 2015, this is the percentage of people who either currently were diagnosed with ADHD or at some point in their life up to that point had been diagnosed with ADHD. So it's not predicting that they will or won't in the future, but up to now, do they meet criteria? Have they met criteria at any point in their lifetime? And that's a stat you'll often hear. Related to that, but a little different, is incidence, right? So incidence is about the number of new cases that appear during a specific period. So the 1 year incidence in 2012 was this. So this is how many new cases were identified. So you need to know kind of both. Overall, how many people were there, and of those people, how many were new cases? When you're looking at new cases, you're looking at trends. Okay, there's this increase in incidence, a decrease in incidence, and why is that happening? Is there better identification? Is there an increase in misidentification? What's going on? So both these numbers are important in terms of understanding patterns in psychopathology and understanding where needs are, and related to that, where resources should be focused. Okay, the course. So again, talking about disorders, similar to talking about medical disorders, physical disorders, you can talk about a course being chronic, episodic, or time limited. So a chronic course would be something like schizophrenia has a chronic course. So that means that once you have your onset, which is the beginning of symptoms, which is often in early adulthood, the symptoms persist across time, and they tend to get worse, some of them. Episodic means that, okay, the symptoms come in, and then they may go away, but then they may come back. So we see that a lot with mood disorders, like depression has an episodic course. Somebody may experience a major depressive episode where they're feeling really depressed, maybe have thoughts of suicide, difficulty eating, sleeping, all those things. And then with or without treatment, they'll begin to get better for the most part. But then it will likely come back, right? Once you have one depressive episode, you're at a greater likelihood of having a recurrent episode in the future. So it has an episodic course, waxes and wanes. Or there may be a time-limited course where, okay, you may have the symptoms and then they go away and you'll never have it again. Occasionally that happens with brief psychotic episodes. Somebody may have a psychotic break where they'll hallucinate and have delusions, and then it never happens again. It doesn't develop into schizophrenia or any kind of schizotypal schizophrenic spectrum disorder. So there are those things too. So it's important to note when we talk about the course of disorder, there's a typical course. So we say, oh, schizophrenia is typically chronic. Depression is typically episodic. But it varies across individuals, right? So we can talk about, okay, for this diagnostic category, here's the typical course. But just like, think back to that normal curve, typical means most people have this type of course. Some people, a very few, as we get further away from that, will have maybe a time limited. Some people maybe have a more episodic. It can differ. All we know is what's most common. Okay, so there's different types of courses. As I already alluded to, when symptoms begin, that's the onset. So you can have acute onset or insidious onset, right? So acute is no symptoms and then boom, a lot of symptoms all at once in a pretty short period of time, very quickly escalating into depression, suicidality, all those things. Or it could be insidious, where you just start to feel a little bad and then a little worse and a little worse, which you may see with cognitive decline associated with some types of dementia. And again, depends on what type of dementia we're talking about here, what the rate of decline is, where you just may become more and more forgetful as it kind of heightens into meeting criteria for a psychological disorder. Okay. Related to kind of course is the term prognosis, right? So prognosis is the anticipated course, and typically we're really talking about the anticipated outcome. And the terms we use here are usually it has a this case has a good prognosis or a poor prognosis. So we expect, full recovery, and they should respond to treatment. We expect symptoms to drop below clinically significant threshold soon. Or if there's poor prognosis, it's unlikely we'll see symptom recovery anytime soon, probably a chronic course, and some significant impairment, dysfunction, possible mortality. Right? Comorbidity, one that I think is mentioned in your book in the first chapter, is probably in there somewhere. This is where we talk about when more than one disorder exists at the same time. Those disorders are comorbid. The person is exhibiting comorbidity. So things like anxiety and depression are often comorbid. Right? If somebody's diagnosed with a mood disorder that has depressive features, they're at increased risk of also meeting criteria for an anxiety disorder, because there's high rates of comorbidity for those disorders. For somebody that has a tic disorder like Tourette's, has a high rate of comorbidity with ADHD. So those things often co-occur, happen together. And we talk about comorbidity. Typically we're talking about, in this class, we'll talk about psychological disorders that occur together, but it could be a psychological disorder with a physical disorder. So somebody that has Huntington's comorbid with dementia. But typically it'll be two or more psychological mental disorders that co-occur when we talk about issues of comorbidity. Okay, so wrapping up, take home. We're looking at if something is normal or abnormal, and if it goes from abnormal to psychopathological. As we'll see in further discussions, there are no clear demarcations. There's no blood test that tells you, okay, yep, once you cross this line here, your white blood cells go here, or your proteins are this high, or your MRI looks this way. Yep, you have it. Nope, you don't. It's a decision, right? And it's a decision based on some evidence, but the boundary lines are blurry. When trying to make the decisions, the decision makers have to take into account those three criteria we talked about, right? Psychological dysfunction, distress or impairment, and then atypical or not culturally appropriate. Meaning one criteria is insufficient for a diagnosis, right? Yeah, that's why there's those three different things, because a lot of times if you drop one off, you can see the potential for abuse of diagnostic criteria, which we've had throughout time, where people get labeled with things for reasons to disempower them. Right? That's why all those things have to be met, or they don't have to be met, they should be met. Because again, somebody's making a decision, and there's not necessarily somebody in the background double checking them. Okay. Also, for each of those criteria we talk about, it's a matter of degree, right? So if you have a little bit of difficulty focusing on this lecture because I'm rambling on, does that mean you have impairment in now maybe you have ADHD? Maybe. How impaired are you? How difficult it is to concentrate on this super exciting lecture, right? Same thing for dysfunction, and if it's how atypical is it? If it's a little atypical, a lot atypical. Well, how much does it have to be? No clear demarcations, but it is, again, a matter of degree, and at some point somebody's going to make a decision. The last bit, just as a reminder going forward throughout the rest of this class, because what typically happens for individuals taking an abnormal psych class or a psychopathology class is they'll be reading through and they'll go, oh, I have that, or oh, I know my mom, wife, sister, husband, partner has that, right? And we tend to diagnose ourselves, we tend to diagnose others, and that's fine. I'm not going to tell you not to do that. It's kind of fun. But I will say that abnormal behavior is fairly normal, right? And when we look at the disorders, each disorder has a fairly low occurrence, right? It's often, 1%, 3% of people meet criteria for this disorder. The most common one, you're looking at maybe 20%. But now if you lump all disorders in and say, okay, well, how many people at some point in their life meet criteria for at least one disorder in the DSM? Well, it's a lot. It's a lot of people. It's like 40%. And that's meeting criteria for a full disorder. if you go sub-threshold, so, oh yeah, I have some of these behaviors, but it doesn't quite meet criteria because I don't maybe have enough impairment, or it doesn't cause me enough distress, or maybe it's culturally appropriate for me. Once you bring in those subclinical ones, I would argue that it's everybody. Everybody can find something when reading about abnormal behavior that applies to them, applies to someone else. And keep that in mind when thinking about yourself, and please keep that in mind when thinking about someone else, that, oh, they're exhibiting abnormal behavior, but then remind yourself, yeah, but that's kind of normal. We're all kind of abnormal in our own unique ways, right? And we'll talk more about that as the course goes on, about how important it is to, when learning about these diagnostic categories, learning about these labels, to not let it keep you from seeing that they're being applied to people. Right? They're not applied to just cases in a book. They're being applied to living, breathing people that have thoughts, feelings, independence. And hopefully you keep that kind of in the background of your mind as you're studying this. All right, that's all for now. Take care.